to the section on surgical videos, and I request all speakers to be on time. It's beyond me, but your video will be switched off if you take too much time. And I also request, as the first presenter is completing, the second person please come to the podium. So we have the first presenter, Dr. PrashantBawankule, Ngenuity, digitally assisted vitreoretinal surgery. Dr. Prashant.
Good afternoon. I would be speaking now on Ngenuity, that is a digitally assisted vitreoretinal surgery. Lot of changes has happened in the way we operate eye. We have moved from Ocutom, where we used to use a cutter rate of 600 cuts per minute, and today we are talking about 20,000 cuts per minute. Weaving systems, we have a wider angle weaving systems, but somehow nothing much has happened in last 4 decades where the way we look at the eye while we are operating, and this is the first change which has happened. And this is what is exactly the Ngenuity, or a digitally assisted vitreoretinal surgery surgical instrument. It means you have a microscope, you have a screen over here, and you have a CPU over here. In fact, instead of an eyepiece, you have a camera which picks up the image, and with this image is further transmitted to the CPU. This CPU plays with the image, it modifies it, it makes it more visible, it adjusts the contrast, the color contrast, and other things. And then the image is transmitted to this particular screen, which is a 3D screen which you need to visualize with the help of a glasses, 3D glasses. It is something like a laparoscopic surgeon who is operating, looking at the screen and operating over here. But the difference is that is a 2D system. Here you are using 3D systems, something like you watch in a 3D video, and this is exactly what it looks like inside the OT. So the surgeon himself is looking at the screen and not into the microscope while he's operating. Is it only a hype, or does it really offer you a certain surgical advantages? If you remember in 80s when Kapil Dev won the first World Cup, this was the TV on which we enjoyed the thrill of winning the first ever World Cup. Then came this bigger screens, then bigger screens, and now we have such a bigger screens. This bigger screen now not only permits you to look what is fallen over this lawns, or you can pick up a spectator who is sitting over there. And that is the fun of this resolution. Now what happens whenever you are focusing with an analog or a small microscope, either you can focus on an image which is close to you, something like an arch, or a valley which is further down over there. You cannot see it simultaneously, but if the computer plays with this image, you can see both this particular, the distance as well as the close things as sharp as you would love to see. And exactly this is what happens in a giant retinal tear situations, where you can see the disc vessels as sharp as the peripheral vessels over a giant retinal tear. I would be showing certain other videos later on. Does high magnification really help you? And why was the high magnification coming in the way of we as a vitreoretinal surgeons before we used to operate? See, the moment we magnified an image, we could pick up even the small things. You can pick up the details of the bark over the tree, or the lawns which were the grass which is lying over there. But the moment magnification happened, it compromised the field of view, it compromised the depth. And basically in this particular cases, as you see, even at such a high magnification, you can see the depth, and this surgeon is chipping off the ILM bits so close, because that depth is possible even at such a high magnification, which was not possible. The other thing is, the moment you have a higher magnification, your peripheral acuity gets compromised. And precisely in an Ngenuity, the CPU plays with this image, and the whole image, whole field of view is enhanced. And so look at this particular situation. Watch here. You are sucking a blood over here, and watch this area. There is a tentacle of a clot which is going, you will see. Had I not noted this, you would have created an iatrogenic break. And that is the importance of having a bigger field of view, and that too at a proper magnification. Second thing is, when you're not seeing clear, you increase the illumination. Increased illumination dazzles your eye. You do not see anything sharp over here. You bring down the illumination, it darkens and you cannot see the sharp. But if it is optimized, you can see all the details as sharp as this. Besides this, the image also plays with the color tones, and so color tones can be adjusted to the best possible things. Other advantages of this particular system are that you have various color filters. For example, in these videos, I will show you A hemorrhage case, now we are using a filter. Because of the hemorrhage, my eyes were getting dazzled, and now with the filter I can use. Now, similarly, while I'm using an ILM peeling, I'm using a particular filter which makes my ILM stand out more better compared to a white light. And all this, whatever images you are going to see, you are going to see it at 1/10 of the illumination which we were routinely used to. And that means less chances of phototoxicity. You have an expanded surgical view, not only you are enjoying the system, the surgery, your whole assistant, your team people are also helping you out. But the flip side is that in event if you have a complication, everyone knows today you have created a mess in the eye. The other thing is, unlike the other microscope where you peep into the eye, into the microscope eyepieces, you are looking straight, and therefore your neck back problems can be taken care. And for all the high volume surgeons, this is going to be the future, and we have to age one or the other day. The other advantages is you have this surgical capture videos, and so this is what it offers. I would show you certain videos where this is a diabetic plateau type of a tractional retinal detachment. This particular case which we are going to operate, we are doing a vitrectomy, and you can see the expanded view. In fact, whatever right now you are experiencing in this particular skin is a 2D image of it, which has been converted from 3D. In fact, 3D is an experience, I cannot put it in words, but this, if you are seeing in a 3D with the glasses, it is a total different field of view, and you can really see. Now you are cutting the peripheral vitreous over here. And as you see, now we are going to peel the membrane. This membrane is so densely adherent to the posterior pole. This is a classic diabetic plateau type of a TRD. And you see the movement of my cutter. This is not an edited part of my cutting. And this speed with which I'm achieving the membrane is possible basically because the difference between the retina and the membrane seems to be almost few centimeters. And therefore, you can further micro-titrate your movement, and therefore your confidence, the movement with the speed with which I'm moving my cutter over there, which was not possible even with the experience of 20 years. And this is the possibility which you can see in this particular case. And because you can see better, naturally you are going to perform better. And this whole TRD we could complete without creating a single break, which was not that easy a proposition in a previous era when we are operating on a routine digital microscopes. You see this particular membranes at the end of the procedure, I would show you. Slowly we are doing it. And this is almost the complete thing. And this was possible because of the depth perception. So magnification in this case does not mean compromise with the depth, and that is the advantage of this particular system. This is a case of a foveus crisis. You will see again over here. Here the contrast is very less. If you see, the RP is less, and in this cases the peeling of the membrane is always a challenge in a very large globe. And if you see, after doing a cutter, this is a peeling. So the image quality is in fact enhanced when I am doing, because peeling an ILM in a foveus cases is always a challenge, especially when it is a posterior staphyloma. And you will see the ease with which we could do. This is just peeling, and I'm using a long dog forceps, which is about 15 millimeter in length, which makes it possible for me to reach out into the staphyloma for peeling this particular membrane. And at the end of the procedure, you will see I had to remove it in bits and pieces because the membrane was really very fragile, and it was very difficult for me to reach out at the posterior pole. And these problems we could avoid basically because we didn't have a very close camera over there. So does it mean that once we have a digitally assisted vitreoretinal system is what the word, the Alcon people use the name, does it mean that that particular OT would be henceforth dedicated only to a vitreoretinal procedure? No. Even this procedure, even phaco's can be possible, so it does not mean you need to create one more additional OT for this particular thing. This is a phaco at my hands, which we are doing on Ngenuity, and now in last 4 months, we have done more than 400 procedures, about 200, 250 vitreoretinal procedures and 100, 150 phacos, including the premium IOLs. And you can see the ease. Here again, when you are doing a phaco in a combined case or even as a standalone procedure, the depth of the anterior chamber is magnified that big. And because the depth is magnified, you can micro-titrate your phaco movements, and the chances of creating more complications are further reduced. And this is a case of one which we are doing. This is a rexis which we have done over here. So it does not mean, that's what I was suggesting to this Alcon people, don't call it digitally assisted vitreoretinal system. In fact, it should be digitally assisted ophthalmic system, weaving system, or surgical system, what you call, because otherwise it gives you a misconception that this system can be used only for this. And to tell you frankly, whatever I have tried to put it across to you, the advantages of this, in fact, you cannot put across everything. An experience cannot be put into the words. That exactly is the difference. Here, all the videos which you are seeing is a 2D image. Once you start seeing it on a 3D screen, on a high quality TV monitors, you will understand what you are missing. And therefore, we feel this is going to be the future of how we are going to look at the eye while operating in coming future. Thank you.
Thank you, Dr. Prashant. In the interest of time, we'll move on to the next presentation. Dr. PiyushKohli will talk about repositioning of inadvertent intralenticularozurdex. Dr. Piyush.
Time they did right from squint surgeries to trabeculectomies to SFIOL I did, Dr. Guru Prasad did a ERM. So it's more of a mind block rather than anything else, that you have to get to that concept that you are looking there and operating here.
Because
and it's the learning curve is not more than an OT.
Because the change of
the
way you see it.
Yes, exactly. And second thing is, what I feel personally is that the younger generation, definitely, they have their more neurons, synapses to be as rigid as ours. So my younger colleagues have picked up the system and they are more comfortable with it and rather addicted to it rather than me.
Thank you. Are you ready?
Apologies for the delay, but I wasn't told a couple of speakers on there. So I'm going to take you to some surgery in uveitis. I don't think anyone's speaking on that. It's not technically
also decrease secretion by directly damaging the ciliary epithelium. We demonstrate the preoperative evaluation and surgical techniques for management of such chronic uveitic eyes. This 7-year-old female child was a known case of juvenile idiopathic arthritis with counting fingers bleeding in both eyes and intraocular pressures between 6 millimeters of mercury for the last 6 months. Ultrasound biomicroscopy plays a key role in this case by demonstrating the presence of cyclitic membrane and ciliary body atrophy. 25 gauge fast reflecting poles were made and iris drop was applied to achieve adequate pupillary dilation. Infusion was switched on after viewing the cannula. Lensectomy was completed with meticulous removal of the lens matter and lens capsule. Complete vitrectomy, including transnode-assisted posterior hilar removal, was done. Careful cyclitic membrane removal was done 360 degrees under direct view of the microscope. Peripheral squirrel regression was used to visualize the ciliary body area. The membrane was slowly segmented into smaller parts with the help of intraocular scissors in all the quadrants, followed by removal with the vitreous cutter. Care should be taken to prevent direct injury or excessive pull to the ciliary process. silicone oil tampon was given at the end of surgery. The patient achieved a visual acuity of 6/12 and 6/18 with 880 glasses with intraocular pressures of 14 and 16 millimeters of mercury in the right and left eye.
Sorry, that finished a little early. I have one more minute. I'd like to add a couple of points to that. So generally, these membranes can be seen in eyes which have been operated multiple times previously. So post-multiple vitrectomies can also be seen post-trauma, can be seen in long-standing endophthalmitis cases, can also be seen in these chronic uveitic cases. I think a distinction needs to be made between recurrent surgery-related cyclitic membranes and or trauma-related ones, because those tend to be vascular. And doing those maneuvers in those is going to be extremely difficult. Whereas generally, most of the time, these de novo membranes which form in surgical, kind of virgin eyes which have not been exposed to surgery, in chronically inflamed uveitic eyes, especially children, don't tend to be vascular. So at least those membranes, if one tends not to hit the ciliary body, don't tend to bleed. So you can actually cut them with scissors or use forceps or use like a hybrid kind of technique as we use there and use cutters to try and get rid of all of them. And the idea is not to go 360 degrees. You might want to depress and see 360 degrees, but if you can free up between 180 degrees or if you're lucky up to even 3 quadrants, 270 degrees, that should sustain the eye with at least some amount of aqueous production coming back. Thank you.
Uveitis have had sometimes vitrectomies for other reasons.
Yeah.
And what I found is that if a person with uveitis, a young age, has a vitrectomy before, unless it's very complete and we've removed the vitreous from the vitreous base, that tends to increase the cases that you've described where you get these ciliary body dysfunctions and you end up having to do the dissection. I like your technique. The use of scissors, I think, is much less traumatic than trying to just remove and pull
with the
off
cutter,
the
it gets
membranes.
difficult. Yes, sir. Yeah, thank you.
Good technique.
Thank you.
So shall I start?
Yes.
Dr. Piyush, go ahead.
So accidents do happen during surgery. So here we present a management of such an accident. It will play the voice. The voice is not coming. A 60-year-old hypertensive male patient presented with macular BRVO with CME, which was not responding to multiple anti-VEGF injections. He was finally advised to undergo an Ozurdex injection. At the time of the injection, the patient moved his head vigorously. On slit lamp examination, the implant was found to be lodged in the crystalline lens. 10 days post-injection, he developed an intumescent cataract. Due to the high cost of Ozurdex, we decided to retain the implant and remove the cataract. However, separating the implant from the cortex in the capsular bag can lead to its accidental aspiration and even zonular dialysis. Hence, we decided to take a vitreoretinal approach for the management of the implant. Following the construction of a clear corneal tunnel, a careful capsulorhexis was done. As a PRCR was expected, a careful hydrodelineation was done while hydrodissection was avoided. As the cataract was soft, it was easily aspirated with low machine parameters. During the surgery, special attention was paid to prevent accidental aspiration of the implant. The implant, along with some surrounding cortex and a small piece of epinucleus plate, was pushed down into the vitreous. through the pre-existing PCR. Now, this cortex can lead to secondary uveitis and glaucoma. Also, the efficacy of the implant can be compromised because of the surrounding cortex. Hence, it has to be removed. But we have to be cautious to prevent accidental aspiration of the implant. Due to the available space in the vitreous cavity, manipulations are relatively easier. We carefully separated the implant from the cortex. One of the major concerns regarding this approach is the faster absorption of the drug in the vitrectomized eye. However, Ozurdex is a sustained drug release implant and has been found to have a similar pharmacokinetics and non-inferior clinical effect in a vitrectomized eye compared to a non-vitrectomized one. With an increase in the use of this implant, such complications are said to increase. We suggest that the implant and some surrounding cortex can be pushed in the vitreous and then perform vitrectomy, rather than doing all the manipulations in the capsular bag. This will not only prevent the accidental aspiration of the implant, vitrectomy can also help in better resolution of the edema.
There are reports in which cataract has not developed even after 1 year of injection. So in that case, it can be retained. But in case a cataract develops early, so we have to operate. And another point is that even if it breaks into the Ozurdex implant, the efficacy is still the same. That has been found in reports. Thank you.
Thank you. Is Dr. Rajan Bhatia here? Okay, so
Are you ready?
are you ready? So next we have Dr. Rajan Bhatia, subretinal pellet removal. Okay, now we are
Sclerotic was closed with 8-0 suture. Fluid air exchange was done. Some amount of subretinal hemorrhage was drained so that we could prevent the migration of the hemorrhage below the fovea. 360-degree endoresin was done. Here this is the comparison of the subretinal hemorrhage before and at the end of the surgery. One question was running during the surgery in my mind that how this pellet migrated subretinally, but the fibrous band cleared it all, that it has migrated through the small hole in the lens. Pellet guns are a form of non-lethal weapons used to disperse the bomb. 317 pellet injuries have been reported. 50% have been in the eye. These are very grievous injuries. Some have lost their eyesight. Could this have been avoided? The answer is yes. Answering the wrong with the wrong does not make it right. But the solution is peace, love, and harmony.
Thank you.
And can I request audio visual people to start the watch? The clock is not working. Now I invite the next speaker, Dr. ManishaAgarwal. Is she here? Thank you. She will be speaking double trouble, right?
So good afternoon, everyone. My case is a one-eyed 40-year-old male patient with a vision of PR inaccurate and a double trouble in the form of a corneal opacity and retinal detachment following a wooden stick injury and corneal perforation. The corneal button was removed with anterior vitrectomy and a temporary keratoprosthesis was placed. View through the keratoprosthesis showed a closed funnel retinal detachment with extensive PVR changes. A small bubble of perfluorocarbon liquid was injected to open the funnel, however, it failed to do so. Membranes were peeled to open the funnel. A small foreign body was found floating in the vitreous cavity, which was delivered out. And more membrane peeling was done. There was leakage through one of the holes of the keratoprosthesis, and the suture had to be replaced with glue applied over it to stop the leakage. This glue, however, got smeared over the keratoprosthesis and had to be scraped, increasing the already existing double trouble. Subretinal glyotic bands were removed, followed by laser photocoagulation, and perfluorocarbon liquid silicone oil exchange was done. Finally, the corneal transplant was completed. At 6 months follow-up, there was a well-attached retina with a vision of 636 N36, and this made the patient ambulatory. So thank you everyone. I just presented this video basically that don't ward off such eyes as inoperable, and they do stand a good chance. Thank you.
Thank you, Dr. Manisha. That was an excellent presentation. Now we have, is Dr. AtulArora here? Dr. AtulArora, his presentation is Extreme PVR, Navigating the Narrow Funnel in Pediatric Cases.
Good afternoon, everybody. In morning, we had nice presentations about dealing with complex retinal detachments. Through my video, I will be demonstrating surgical steps of managing such situations in pediatric population. Voice.
Pediatric retinal detachments present many inherent management challenges, including late presentation, bilateral involvement, poor correlation of function functional and anatomical outcomes, and the need for a prolonged follow-up for visual rehabilitation. Examination under anesthesia is often recommended for detailed preoperative evaluation and surgical planning. In this video, we describe the surgical principles for management of such patients of complex pediatric retinal detachment. A 3-year-old boy who presented with no vision in his eyes for 2 years. On examination, the left eye had atrophic bulbi, whereas the right eye was light perception with inaccurate projection of rays. The right eye had an old total rheumatogenic retinal detachment with a superior nasal giant retinal tear with proliferative vitreoretinopathy grade E3. The patient was taken up for surgical management. A 240 encircling band was past 360 degrees. A standard 23 gauge 3-port pars plana vitrectomy was started and a core vitrectomy was done. The disc and posterior port would still not be visualized. Further membrane dissection was done with the help of forceps and vitreous cutter to open up the funnel. Perfluorocarbon liquid was used as a third hand to assist in the membrane peeling. A slow and patient surgery is required in such cases to meticulously dissect out these PVR membranes from all the quadrants and remove the densely adherent posterior hardware. PFCL can be subsequently added to iron out the retinal folds. A 360-degree endolaser was performed after flattening the retina, and cryotherapy was applied at the edge of the giant retinal tear. The case was completed with a PFCL air and air silicone oil exchange to provide long-term tamponade. Post-operatively, the retina remained attached and the vision improved to counting fingers at 2 meters after silicone oil removal. To conclude, pediatric retinal detachments are a management challenge. Even though they are often associated with a guarded visual outcome, careful ophthalmic evaluation and management of these children can provide ambulatory vision and profoundly impact the lives of these young patients. Thank you.
Thank you. It was an excellent video presentation. Next, we have Dr. AkshayAgnihotri. Are you here? Good. So he'll be talking about rare video showing removal of a live worm from the vitreous cavity using a unique approach.
Good morning all. We are here with our video presenting a unique method of live worm removal from the vitreous cavity. As we all know, ocular worms are not a rare entity in ophthalmology. So here we present the case of a 60-year-old female who presented to us with complaints of sudden dimness of vision and floaters in the left eye. On examination, her best corrected visual acuity in right eye was 6/6 and left eye was 1/16. On further examination, fundus of left eye showed a live motile worm floating in the vitreous with one end attached to the retina over macula. A short course of anti-helminthic drug was given to the patient, but there was no response. So eventually, a pars plana vitrectomy was planned for her. As we can see here, we did a 23 gauge pars plana vitrectomy. First of all, with the help of endo-illuminator, we inspected the vitreous and retina and saw a live floating worm in the vitreous with one end attached to the macula. Then we did a conjunctival peritomy to secure site for our 20 gauge port. Then we prepared a 20 gauge IV catheter by cutting it at one end and the other end of which was attached to the silicone oil extraction cannula. Now with the help of MBR blade, we made a 20 gauge port. We first of all did a core vitrectomy, trying to keep a safe distance from the worm so as to remove it in toto. After core vitrectomy was over, we introduced our self-designed 20 gauge catheter through the port and kept it as close to the worm as possible, and then with the help of an active suction, we aspirated it out in one go. As we can see here, the entire worm has been extracted in one go and is still alive, which was later sent for histopathology. Lastly, all the port sites were well secured. On histopathology, the worm was found to be Wuchereria bancrofti. On subsequent follow-up, we had a happy patient with a dramatic improvement in the vision from 1/60 to 6/9. Thank you.
Excellent.
So this was a unique technique to remove the worm. Like we got the whole live worm removed using this technique. So that was what we wanted to show. And the patient was quite happy with the visual improvement from 1/60 to almost 6/9 in this case. That's all. Thank you.
So could you have tried just a soft tip extrusion? 20 gauge soft tip?
It was the one end of the worm was stuck at the macula actually, so I don't think it would have come out easily.
But you could have sucked it out with a soft tip also, no? With active suction?
Could have been tried, I think, but.
Yeah, but excellent video. That's great. Thank you. So now we have Dr. Aurora.
Stay in the mid-vitreous, try to remove the hemorrhage, and try to get some retina view. The reflected light will do the rest, and then your surgery would improve. It's very important for the long-term success to ensure that you induce a PVD wherever it is possible. And once the PVD is induced, you may be able to induce it in one particular quadrant. And then if this hemorrhage is not coming off, we will induce the PVD. And then because it is subhyaloid, so you induce the PVD and it becomes much easier to remove the blood, and it comes off very easily with the cutter itself. Once this is done, you can go ahead and do the endo laser and the surgery gets completed. So if there's an inadvertent break or there's a pre-existing break, that should be lasered. And so here, this is to demonstrate removal of these membranes. And if you feel that you want to get a better pictures, better photo, better video, or you want a bimanual surgery, then it's good to put a chandelier system. You can put one or two of these lights. And this would improve your video quality. The same membrane being visualized now with the chandelier being on, there are no dark areas and it's possible to peel off these membranes much easier. Once these membranes have been removed, you can use the cutter to do the rest. You don't have to go all the way out to do the peeling. You can segment these membranes, peel them off and do a combination of these different techniques. So now the cutter, we go inside and remove these membranes with the cutter, and So with the small gauge cutters, most of the things which we earlier used to do with a forceps or scissors can be done. And then I always like to mop up the retina because I don't want to leave any heme on the retinal surface, and a soft tip does the job very well. As I'll show you in the next case, I like to actually blow the blood off the retinal surface. So this is again a membrane being removed with the chandelier on. And here you can see that this is the best, is you actually blow the blood off by the back flush, and the blood becomes loose, and then it can be aspirated off very easily. So you don't have to even touch the retina, and this works extremely well. So this is doing a bimanual surgery, and that's where the chandelier system comes in. You can pick up the membrane with a forceps and use the cutter or a scissor to remove the entire membrane. So this has to be done, like in this particular case, numerous such membranes have to be released to get the retina back in place without creating a break. And this is the end stage. It's a very bad complex retinal detachment, ended up with this fluid exchange being done, which can be followed either with gas or oil with adequate amount of laser. So this set of videos was just to demonstrate certain basic principles which we do to manage cases of diabetic vitrectomies. Thank you.
Thank you. It's a great compilation of cases. Now, next.
We need to know what is lamellar hole associated epiretinal proliferation. It's a thick homogeneous medium reflective epiretinal in location arising from margin of a lamellar defect, and it's absolutely non-tractional, which is different from an ERM. So we need to distinguish how an ERM and an LHEP is. ERM is a thin hyperreflective membrane with skip areas between the contact, whereas LHEP is a homogeneous material, epiretinal, and it's uniformly in contact with the retina, and it's non-tractional. So there are various theories. The most accepted is the Mueller cell theory, where there's a glial cell proliferation. So why do we need to know the two differences? The LHEP causes a larger tissue defect, a disruption of ellipsoid zone, and a poorer mean visual acuity. So our case experience.
69-year-old female presented with diminution of vision in left eye since 1 year. Vision in left eye was 6/36 in 18. On OCT, it showed presence of lamellar hole with substantial material of homogeneous medium reflectivity on the epiretinal surface that demonstrated contiguity with middle retinal layers. It did not show presence of contractile properties or tractional effects such as edema or distortion. Hence, the diagnosis of lamellar hole associated epiretinal proliferation was made. Tricot-assisted PVD induction was performed. BBG was injected. Tissue was tried to be peeled from the retina. Repeat BBG was injected because ILM did not take stain previously. Tissue was found very adherent to the underlying retina. Cheesy material was seen and it was tried to be peeled from the macula. After multiple attempts, it was possible to remove complete epiretinal tissue, after which ILM was also peeled and inverse flap technique was performed. At 1 week follow-up, vision had improved to 6/18, lamellar hole had closed, epiretinal tissue was found to be absent. Immunohistochemistry confirmed the diagnosis of glial tissue by showing strongly positive results for glial fibrillary acidic protein, hence confirming the diagnosis of lamellar hole associated epiretinal proliferation.
Thank you, sir.
So we have time for questions. We have time for questions. Any questions for surgery for LHCP patients?
Yes, sir. So there was a study conducted across 72 patients where they found that the lamellar hole associated epiretinal proliferation over a period of time, the size increases with a decrease in the visual acuity and also ellipsoid zone disruption. So this, in case if over a period of time, if this increases, if progresses, one study proves that the visual acuity improves. Whereas there is another parallel study with a smaller size of population where they have told that despite the surgery, the vision did not improve, but it was stabilized. So one indication for an lamellar hole associated would be over a period of time if the vision drops down and the size of the LHCP increases, sir.
So we have a question.
Sir, my question is for Dr. Bawankule, sir. Sir, we enjoyed the luxury of having Ngenuity in our institute last year. So since I have not been following up on the Ngenuity, so I guess you are the better person to answer this. Apart from all the advantages that you mentioned, so the one disadvantage which we faced with Ngenuity while we worked last year was that there was a significant time lapse.
No, the thing is, what I wanted to show in that particular video was the difference between the membrane separation from the retina. When you are visualizing with a microscope, you see a very small distance. So when you are moving your cutter, trying to peel it off, lift it off, you are very hesitant to be very fast. You are doing it in bits and pieces. You lift up and then. Here, because the separation is so big, that is magnified, so you know that your micro movements of your cutter is well titrated accordingly, and so you can move. So that particular unedited part of moving, that cutting the membrane, was what I wanted to impress upon. So it's not regarding experience. I mean, is experience, yes, we were doing, but I couldn't do that fast. And I think learning curve is more of a, it's again I would say it's a mind block. I think I was comfortable right from the next case, I should say. First case, second case we started. First case also, it's not a learning curve. You are thinking something else. You are doing something new, you are doing something new. That keeps on bogging you.
Right.
Rather than you having a problems in learning it.
Thank you, sir.
Thank you.
Thank you. With this,